I can't believe you got up so early to come down and hear this. I hope that you'll think it's worthwhile. Anybody had the Joint Commission come through recently? Anybody? Did you find they were particularly interested in your management of psychiatric patients in the ER? Because the word on the street is that this is a bit of a focus. And I will tell you that at my own institution, our last site visit for accreditation, and this was at LDS Hospital, the former flagship for Intermountain Healthcare, we were cited because we held the psych patient for 17 hours in the ER in a safe room, okay? It was locked. The Joint Commission did not like our process, okay? And we literally had to have a crisis meeting with our C-suite people, ED director, lawyers, and so forth, up until between 1 and 3 in the morning, hashing out a new, process that would cut muster with the Joint Commission. They did not like the way we were doing it. In particular, they do not like patients who are locked and not observed. So a part of this, I will show you, should you need something like this, what Intermountain developed for all of its hospitals as a way that we would manage this psychiatric burden. Sometimes I think the Joint Commission, and I'm pretty vocal about this in what I write and speak about, they just do not have a clue as to what our world is like. And when I describe to you what we are doing now, that was what they required us to do in order to keep our accreditation, I think you'll be stunned, because in terms of manpower and so forth. So I had been interested in this, by the way, before that. I did a little stint with the Institute for Healthcare Improvement, IHI. They had what was called the ED Collaborative. Anybody by any chance participate in that? It was ongoing for about 6 years. You could join for a 2-year stint, and we had 34 emergency departments from really around the world. We had one ED from Okinawa, and we marched through time trying to improve our processes together. So it was the collaborative model for healthcare improvement. And actually, it was by the request of the EDs in the collaborative that I first put something together about managing these difficult psych patients. As I say, my interest became more intense after sweating out what happened to my hospital with the Joint Commission came through. So we're going to give you sort of a model and a way to go through this. First, the magnitude of the problem. I don't think that many people even realize how difficult this is, although I notice it in the nursing journals now. More and more you're seeing articles about the violence and the aggression of patients in the ER against nurses. We'll identify who's high risk. There's definitely things that have been shown out there that help you sort of hone in on who's going to be trouble. It's not always who you think, by the way. Then how do you develop a process, and what should be the focus of your education for your staff and for your department? So the magnitude of the problem. First of all, as you know, the psychosocial burden is increasing. Has anybody actually tracked numbers for how many chief complaints are of a psychosocial nature? So it can be overdose, drug abuse, acute psychosis. Anybody tracking? And aren't you clearly seeing the number that come to your department going up? Ours is on a par with chest pain. Ours is on a par with chest pain. And our resources are decreasing. I can tell you in my community, in the period between 2000 and 2005, okay, the mental health burden doubled, the number of places to send patients halved. Tell me how that's going to work. And this is why we are holding these patients in places that were not designed for that kind of a thing. And then to add insult to injury, to have people like the Joint Commission coming in and monitoring you and holding you to task on this with things that are often unreasonable, it's just really making it very difficult for us. And our physical space isn't designed for it. Is there any sense that it's going to get better? Not really, although you hear a rumor that some of the iterations of health reform may offer a little more funding for this. That's the key, right? Why did the resources dry up? There's no money in it anymore, right? There's no money in it anymore. And so follow the money is what my husband always says, and I think that's really true. So if you have an electronic system, you can just decide this is going to be our mental health bucket. Put the chief complaints that you want to be in that bucket and start tracking your numbers. And as I say, you're going to see them continuing to rise. And I think it's worth having that data when you go talk to the C-suites about the difficulties you're having, because I'm not sure that they even always get the trouble that we have. So as I mentioned, in 2006, for us at LDS Hospital, and we used pretty strict criteria, our psychosocial chief complaints matched our chest pain chief complaints. So that's a lot of burden. And that's just showing you it. Then in terms of the violence piece, if you do Medline searches looking at reports and papers and so forth about violence in the healthcare setting, look at how they go up. You start to see a blip at 90, and look, by 2004, and it's still rising. According to OSHA, just general workers have a 2 in 10,000 chance of being the victim of some kind of violence. So you fix a guy's car and he's unhappy with the bill and he decks you one. So that's your risk just in the general world. We're almost 5 times that in healthcare. 5 times that. And it's grossly underreported. And I always say this, because why wouldn't it be? If you're a nurse and a patient slaps you, what will you have to do about it? Probably an incident report, right? You're going to have paperwork. Wouldn't you just like, shoot, I just want to get home. I had something to do with the kids. Wouldn't you just dummy up? And we think that that's really the case, that it's grossly underreported. 45%, almost half of violence in the workplace takes place in a healthcare setting. What the? So I'm thinking I'm totally dressed wrong for work. Lab coat? Give me a flak vest, right? I mean, seriously, we should be ready for combat, I think. The numbers just are very astounding. And I mentioned this, I think, yesterday, that 9,000 nurses and healthcare workers, they're either injured physically or verbally abused every day. That's a boatload of people, isn't it? You know, that's a boatload of people. So who's at high risk? We need to think about the patient and his characteristics and the workplace and those characteristics. And then also about what we can change to make it safer. So the antisocial personality, clearly. Mood disorders. So your borderline patients, for all the commotion that they create otherwise, they're not likely to hurt anybody, okay? The mood disorders are not a particularly high-risk group. On the other hand, the psychotic disorders, delusional, mania patients, anybody having command hallucinations, showing poor impulse control, this is the prototype of who's going to hurt you possibly. Now, how many of you have your mental health records for patients protected and not easily accessible? Or do any of you have that? Until 2 years ago, we had that. So here I am in the ER, and since the best predictor of future violence is past violent behavior, not only was it not flagged to warn me that this dude could hurt me or my staff, I couldn't get at that. Only the crisis workers, case managers, psychiatrists, and so forth could access those records. Dumb. And you should have it when you go home. One of the things that you could do to protect your staff is have some sort of an icon or symbol or noting in the medical record that a patient has a history of violent behavior, so that everybody knows right up front and we can kind of be prepared. People that are being involuntarily admitted, when you limit eating, drinking, and what's the one they really hate the most? Smoking. Doc, can I go have a cigarette? You know, and often it's really difficult, isn't it? Because how many of you have had people, you even take a sitter with them to go out and smoke, and they elope? Have you had that? I've had it. We're chasing them down the street with their buns sticking out. One guy tethered to a stretcher with a handcuff, biffing, and trying to get down the street with this thing. It was pretty hilarious. And then during transport, and let me just say that again. So 2 big take-home points, if you only took 2 things home. Biggest predictor of violence is past history of violence. So this would include somebody that has been in prison. Maybe not, you don't have a record of him hitting anybody in your hospital, but he was arrested and in prison for assault or otherwise, okay? And then your highest risk time or sort of situation is during transport. What other things help put us at risk in terms of our facility? We're understaffed, lots of activity going on, there's long waits, and again, that transporting thing. This is every evening at my place. How about you? I mean, I'm always at risk from a facility standpoint. Other elements that are associated with the risk of the patients acting out when they're overcrowded in its uncomfortable space. That's probably most ERs, to be honest. When there's no clear policies and procedures in place for this, and when staff are working alone. And I very much worry about my night staff. Right now, I work lots of nights. That's been my preferred shift for decades. And I have some very, very nice, but young, petite, pretty nurses that I get scared sometimes when it's just us down there, for what could possibly happen. And you sort of have your antennae up for these patients. Also, how's your lighting? We talked about this in terms of design yesterday, where there's dark corners and so forth. This is dangerous for your staff. How many of you have a pretty tight visitor policy at your place? Do patients have an identification telling who they should be seeing and so forth? I mean, I'm now seeing people putting a sticky tag visitor and so forth. But you know, I think you should go further than that. I should say what room they should be in, just that room. The patient's in room 3, the visitor can go to room 3. Don't you agree? I mean, and I remember, okay, kind of funny story. I trained at Grady Memorial Hospital. It's kind of like a MASH unit in Atlanta, okay? So I'm the pit boss on the surgical side of the ER. And we used to work 9 on, 3 off, 12-hour shifts. We were trying to kill each other, I think, truly, you know. The RRC wouldn't stand for it now. In any case, so I'm down in the trauma room, and we had a stabbed chest that was going to need a chest tube. And there was a young man in scrubs, and I'd seen him like working the last 3-4 nights. And so the trauma chief says to me, "Do you want to let your intern put the chest tube in?" And I said, "Oh, he's not my intern. Isn't he your intern?" And he goes, "No, he's not my intern." So he turned to the dude and I'm like, "Who are you?" And he goes, I'm pre-med, pre-law, pre-vet, I'm like, "What? Where, are you in school?" And he goes, yeah, University of Cincinnati, University of Texas, He was a psych patient who had found his way down an unlocked door through the back stairwells, which this is a labyrinthine hospital, 1,000-bed hospital. They don't make those anymore, pretty much. And he would come down the ER, and do I dare tell you this? He had been sewing. He'd been sewing patients, and he actually did a pretty darn good job. So I thought he was an intern. Well, and of course, the media got hold of this, and people were coming, "I want to come in and see if my stitches were done by that psych guy or a doctor," you know, and it was very bad press for our ER. So can you imagine? But it just shows you, we often have operated very loosely with who's in the department. How would you see somebody and you have no idea who that guy is? You know, he could be a terrorist for all you know. And so tightening up that visitor policy and identification, and like I say, I'm all for the patient's a visitor, you could put their name and where they should be allowed to go. Because haven't you had it where you find these visitors going through your cupboards? We had one guy, and he had a suitcase that he was putting stuff in that he was just going to help himself too. So having a little bit more control of that is better. And inadequate security. And I say this all the time. This guy is important to you, even if he doesn't have weaponry. His presence is important because it helps to keep people's behavior in check. It helps to reassure the other people in the department, especially if you've got somebody that's loud and sort of out of control. Just having him around is a good thing. How many of you have police, off-duty police, or on-duty police in your department during peak hours? Anybody? You know, you used to see that. I'm like, bring that back. If violence is on the rise in my department, bring that back. So here's a case presentation. 30-year-old man with a history of incarceration and methamphetamine abuse. Do you know which state has the highest per capita methamphetamine use in this country, folks? Iowa. Utah. Little Utah, where they don't drink, smoke, or have a Coca-Cola. They partake of methamphetamines. Interesting tidbit. In any case, so he's brought in by the police for evaluation. He's found downtown at the stadium shouting at people and making menacing gestures. What in there already tells you, ding, 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 danger, Will Robinson, at risk kind of a situation? Incarceration, right off that. Uh-oh. Okay, what else? The meth, to be sure, right. And then, so what do you think about, he's shouting even at police. Right? This is a guy that's really having a hard time controlling his impulses, right? And making menacing gestures. So all these things are on our checklist, and most of you should have at your intake, and I don't, post it where you're doing your intake, the high-risk sort of things that should get your staff aware, this is high risk for a sort of an outburst. When they are very blaming others, they demand unnecessary care, they accuse the staff of being against them, i.e. they're paranoid. All these things should tip you off that you may be out of trouble. If he tells you he's losing control, right, and any discussion that goes to weapons, oh my goodness, okay, ding, ding, ding again. So, because you see where his fantasies are going. And all these things, and you can even, there's sort of a physiologic thing sometimes. When they're sweating, pacing, looking furtive, you should be very nervous about this. But then, so being nervous and identifying it, then we need to have a plan, don't we? And the trouble is, he may see you like that. You're trying to talk to me, which, by the way, I used to make my kids' Halloween costumes every year. This was a personal best. We did them eggheads with paper mache in the kitchen for about a month. That was my personal best, the aliens. Anyway, so you've got your high-risk checklist, a few additional things, stressors in life, divorce, losing a job, financial problems. Anybody find with the economy that you're getting more patients presenting, complaining of stress and a lot of difficulties, and sometimes tipping them over because of the financial stress? I noticed that as soon as the economy started to dive, that I was getting more people that were reporting that to me. So I say, is he high risk? He is. What's your process and what training does your staff have? Remember, we can't do this to them. I mean, this is really the rub, isn't it? You can't restrain them, right? We've got pretty strict restraint guidelines now from the Joint Commission. We can't lock the door and leave them there. I mean, this is getting more and more difficult. So I have to say, I'm becoming more and more of a fan of the chemical straitjacket. So if you used to use, who remembers doing 5 or even 10 of Haldol IV? Oh yeah, he's down, okay. But now you also have Geodon, right? Which is very nice because you don't even have to have an IV with it. If they'll take it, PO, fine, but you can just, inject them. And I find that Geodon works as well, also. In fact, sometimes too well, because when they wake up 8 hours later, they seem like they're together. The crisis worker that evaluates them thinks they're fine, sends them out, and then they're back the next night. Anybody doing that with any of their patients? Revolving door psychosis? So anyway, so this was what Intermountain Healthcare's executive leadership team and medical director and so forth came up with at 1 in the morning to try to save our accreditation when the Joint Commission threatened to pull it. So we said we would have this high-risk checklist. And by the way, if you want to email me, I will send you all the whole package, the whole paperwork package, if you would like to see this for your organization. My feeling is, and I'm a firm believer in this, you don't always have to reinvent the wheel. So if you got something the Joint Commission kissed, why not? So just email me. I've probably sent it already to like 20 different departments at their request. So you're going to activate the high-risk patient protocol. And it goes like this. First, you take their clothes, you take all their belongings. We have lockers now in this little space with a lock. Put all their stuff in. They're in a gown, so we've taken everything away from them that they could make mischief with. Then they go into this safe room, okay? And our safe room has a window. Sometimes we have more than one need, and so we have to spill over to other rooms, okay? Then we immediately upgrade the ESI to a level 2. And the physician can get in there or the crisis worker can get in there. Either way, but the idea is somebody in there quick. We're going to expedite this, even though we're busy. This one's going to be a management issue, so let's just get in there and come up with our plan. And then we have created another position, and this is what I told you that I just can't believe we're doing, but we're doing this. It's called the PSA, Patient Safety Attendant. Because the Joint Commission said you can't put them in a room and lock the door and walk away. You must observe them. Does anybody find this outrageous? So I don't have enough staff as it is to take care of sick patients. Now I've got to dedicate a PSA. Yeah.
We had come through at our triage area, one of the triage rooms, we had security watching an ASI2 that was waiting to go in the back.
Yeah.
And they told us to treat that as seclusion.
They were treating that as seclusion?
It's created a restraint because it's seclusion, and they're still a triage. There wasn't a locked area. They had to be with us. They were getting very, very tight.
They are. So did you all hear that? So he's saying that they had somebody waiting to go back in their little triage area with a security guard watching them, and they were accused of basically that was like restraining the patient. This is like restraints, and you're somehow in violation. What did they want you to do?
The question that the Joint Commission reviewer asked was, she asked the security guard specifically, if this individual attempts to leave the room, what are you going to do?
Okay.
And he said, stop the patient.
Right.
Put him in the room. As soon as he said that, then what she said, it's considered a restraint. You need a doctor's order. You need every 15-minute observation. All that charting with the behavioral restraint documentation is what was needed.
So my sense hearing this is they're making it up as they go along. It's like no matter what you do, because I would have said you guys should have been in great shape with what you were doing. He was being detained in a sense, but you had somebody observing him. So I mean, gosh, folks, I don't know if there's like any one answer then that's going to fit for everybody, but I will tell you this: you're going to look a lot better if you can show that you've articulated the process and your staff knows the process, whatever that process may be. This got us by. Now, I honestly, I'm just stunned because I just think, you know, and now mind you, what we also did was we took data to administration to show them what this burden was in terms of staff hours, in terms of the percent of chief complaints that now are this, in terms of length of stay of these patients, how it had literally, you know, gone up exponentially, and use that to make the case to our administrators that, okay, if we have to do this PSA, which you C-suite people crafted, by the way, you know, then you need to help us staff it. And so now we're not required to use ED staff. They call someone, a tech from another floor, they call in, they have an on-call list for techs. It's not solely our burden, thank goodness. Okay, so keep that in mind as well, that if you're having to do something like this, part and parcel of it is we don't own the problem entirely. You know, the hospital's got to help us. And mind you, we have a psych unit, so sometimes the delays are just like any other admitted, boarded patient, you know. We have delays of that nature. And so now the hospital is incentivized to get that psych patient up because if not, it draws a tech from someplace else, okay, to be a PSA. So what if things escalate? So mind you, I want you to have something like that articulated for the Joint Commission and clearly in your, you know, your manuals and so forth, your staff trained in it. And then I also want you to be able to answer the question and say, well, what if it escalates? And I don't know if you guys remember this, but we had a case in Utah where a father his wife had a baby. I think he had postpartum psychosis, and he came in the ER with a firearm and held that hostage for a number of hours. So, you know, and part of the issue there is no one had a plan. You know, no one had a plan. Everybody was very frightened. So your plan may look something like this. Overhead page, all male staff to the ER. We have a security line to the police to get them into a call, like a, you know, alert. Or you have some way of paging security, something that just shows that you're going to get, especially like I say, think about those cute little night nurses. Like I say, we're an all-girl ship on our night shifts very often at the place I work the most. Yes? Yeah.
Misrepresentation sometimes. And often, even when they're escalating with the male nurses, it becomes almost a staring match.
Yeah.
You feel it going up. It's the females, as long as you know how to handle a situation like that. I guess.
So you're saying your sense is that maybe sometimes that can dissipate the you know, anger and so forth. Maybe I've not seen any data on that, but I also just, it feels like a very vulnerable situation to me. And I mean about 2 months ago, a patient threw a stool at me. I mean, I don't feel protected at all as a female. I really don't. But maybe you're right. Maybe you're right. Maybe bringing in the force is not the best plan, but most of the stuff that I've read recommends that. That you basically call in a team and present to the patient, you know, odds that are overwhelming. You know what, dude, don't even go there, because look, you know, we... Okay. Okay. All right, your point's well taken. All right, I'm going to keep going because you know what? We're supposed to start at 8:15, and we don't have any great world-shattering comments to make to you for 15 minutes, so we'll just keep going with this if it's okay with the room. So we said identifying high risk is the first thing you're going to train your staff so that they don't get blindsided and they are aware of this. Remember what I said, inexperienced young nurses, they're not that worldly. let's give them some tools to recognize when they might get into trouble. And then you can teach some scripting, body language, and then how to get out of a dangerous situation. So this is so funny because I know she looks harmless, but the last patient to grab my stethoscope around my neck and try to strangle me with it was a cute little lady like this who was psychotic. And she swore her full head off at the time. So that it's only going to be these menacing dudes is probably wrong-minded as well. In any case, so the idea that you demonstrate respect for the patients even when they're acting bizarrely and so forth, we kind of get that. For the truly psychotic patient, I'm not sure it works, because remember, they see you as those green-headed monsters. Someone pointed out to me in the last time I gave this talk, this nurse really is in a dangerous situation, right? Because remember, maybe she's not as sweet as she looks. Scissors, hello. All this stuff around her neck that could be used to strangle her. And so it's worth teaching your staff a little bit about, okay, for this patient when I go in the room, I'm taking all this stuff off around my neck and I'm taking off my scissors. And I don't think we think like that, do we? I know I don't. And as I say, I've gotten into trouble for it. So then there is some scripting, just sort of little things that you're going to say to try and talk a patient down. I can see how important this is to you. The guy wants a cigarette. You can't let him go out and have it. Can you help me understand how? I mean, the whole idea with these sort of scripting situations are trying to get the patient to participate with you in a plan that would help diffuse the situation. And you're going to start your sentences, and the way you communicate, you're start, I'm sorry you feel this way. We are here to help you, and so forth. Not you. And the other thing is, because you know what you do? You know these people piss you off, and this is how you talk, right? You can't help it. It's like, and you do this. And so we're going to talk about some of the body language issues. So 80% of communication is nonverbal. 80%. Keep that in mind. So somebody's saying something to you, but what their body says may be giving you a totally different message. So, and it's hard to not frown or shake your head. This is good. And actually, did you know, women are really good at this. Men need to learn this. This is a very, affirmative kind of a behavior, shaking that head up and down, not side to side. Then when you're talking with them, to have your hands at your sides. And you watch. Next time somebody's really in your face, you're going to go like this. And you're going to go like this. And that's just how we respond. We're sort of wired in that defensive way. And see if you can kind of work on that. Not this, okay? And then this was sort of interesting. So you want eye-to-eye contact, but get this. This is less aggressive than this. So they say, put your body at an angle and go, look, and mind you, these are very open gestures and, not threatening. Like, I am so sorry that you're feeling upset like this. Listen, as soon as someone can take you out for a cigarette, we'll try to do that. So very, not this, which is, look it, dude, you're not getting a cigarette, because that's what you would be wanting to do, right? That would be your sort of, intuitive response. And then disengaging from an angry person. So, and does your staff, like this is so basic, but I still don't always see it. How do my nurses get there in the corner and this patient who seems very volatile is by the door? You watch in your department, they don't know this. I think most everybody in the room, that is so, you learned that, decades ago, and you consider that common knowledge. It's not. These new nurses don't get it. So they get themselves in a situation where the dangerous dude is between them and the door, and they're back in the corner. And so we need to remind them. Yeah? Uh-huh. Uh-huh. Yeah. Yeah, I think that's a great idea. There are little training modules that people can go through that sort of teach them some of this. And when you're thinking about the statistics and how prevalent this is, it would seem like the time has come for this to be part of, how many of you have different modules that your nurses have to take? It could be wound care, it could be, don't you have certain training modules that every nurse coming to work in the ER has to do? So why not one on managing dangerous patients and defensive behavior and so forth. So the idea is you're having this dialogue with the patient as you're backing out of the room, right? And so I can see that you're furious with me, and you're trying to get out to a safe position. And mind you, I would hope that, and I think that most ERs, especially night shifts, it's really one of the most team-oriented groups of people, a little microsystem. Don't you feel that way? Your night shift, people watch out for each other, nurses, docs, I mean, it's just a different kind of a deal. And so I would hope that no one's, somebody's sort of watching Tina to see, where's that guy that was yelling? Where's Tina, like kind of paying attention. But if they do get into this predicament, you're saying these things to help you disengage, little scripted things so if they're nervous, and then to tell, I'm going to be right back. Let me go talk to the doctor and see if we can't work something out, that kind of thing. Just to help her get out of the room and then out, lock the door, and to heck with Joint Commission, right? So facility changes. These are mostly pretty cheap and very good ideas. Curved mirrors. How many of you have corners? Like I have a bunch of them in my ER that I can't see down that hall. And I've had it where someone's yelping and I can't even tell what's going on until I run the length of the hall and can see. So how many of you have curved mirrors in your ER? Oh, good. More and more. Good. This is a good safety thing. Closed circuit video, especially, like ours, we have all the psych rooms monitored with closed circuit video so we can see, but I'm worried about till we get them back in a place like that. Then limiting the access. How many of you have ways, so you have your main entrance that the ambulance come in. You probably have a ambulatory entrance, but how many of you have a bunch of other ways that people can get into your department? Back halls, the rest of the hospital. I know, so, and are they locked at night? Hopefully more and more, but I'm still seeing a lot of free thoroughfare in especially smaller ERs that are not paying attention to these security issues. I believe they should be locked with codes. Maybe you use your ID card or you use a keypad to get in, but it shouldn't be a free-for-all that anyone can come down to your emergency room. We talked about bright lights. What about, would your staff know, so if we have a gunman in this department or heaven forbid somebody comes in with bombs strapped to them, would your staff know where to go if you asked them? Do you have a plan? So that's something to think about as well. Where would we go? What would be our plan? You could have an exit plan or you could have a safe room plan. But the point is, most departments don't think of that.